All right. So, why a listening session? That's going to be top of our agenda today, right? So, we're going to talk about that. What is a listening session? And, listening sessions and focus groups, they are pretty much more what you call qualitative data, meaning you're going to hear some in depth knowledge and content and information. And it's not a high quantity. We're not dealing with hundreds or thousands of respondents and participants. We're getting a smaller group of participants to look at the quality and the depth of this data. And as I said before, we're going to use vignettes, but we're also going to use a case example, listening sessions to understand barriers to hospice and palliative care utilization among communities of color. This is a listening session series that occurred in Howard County um, last year. And in this case example, we're going to go over starting the process for a listening session. What are some of the foundational partnerships? What are some of the first steps to kick things off? And then what's the process of conducting one and facilitating one? And then we're going to follow up with an example of a listening session that went really well and the community was highly engaged. And we'll go over another example when the community might not, where they weren't quite as engaged. And then we're going to look at the findings. And looking at the findings is important because we want to be able to spend time today testing this qualitative approach with the quantitative. So I'm going to show you the next slide here. There's one window here that's pretty important. And this comes out of Morgan State University's needs assessment that they did with the Family League. But it says to a great extent, the findings of your focus group or listening sessions and the related aspects, they should relate to the quantitative data. So in a great extent, what you learn in your listening sessions should have some relation to the quantitative data and whatever surveys or tools that you use to get that quantitative data. So they shouldn't be totally separate. Um, they provide a window into the real lived experiences of the communities. Listening sessions are also a tool to help with the unvoiced and undervoiced in the community. So if there's groups and there's insights out there that they have, and you want to learn about those insights, you can better serve them. A listening session is a great tool to really specifically focus in on some core groups that you otherwise might not have reached with a survey. Um, and then you might think, well, then why do we need a listening session? We could just use a survey, right? A survey, well, that can be emailed out. It can include hundreds of people, thousands, tens of thousands of people, right? Or we could do some kind of online poll. And these are great tools. And when you look in Baltimore City at the various community needs assessments done by various hospital organizations and universities, they use a lot of survey data, right? And that is a good, solid tool. But we know that survey data doesn't reach everybody, right? So what do? We use other methods. We use focus groups, we use listening sessions to really go a little bit deeper and in the process catch some communities that might be undervoiced. So you've heard me already mention focus group and listening session a couple times. I just want to take a quick moment to go over with you some of the core differences between the two. A focus group, that should include, according to the AARP, um, about 8 to 12 participants. They might represent um, stakeholders, leaders in the community, or people impacted by the project or initiative you're proposing, the project or initiative that this focus group is about. A community listening session, it's a bit broader. Typically, it's not going to be a very small amount of questions. Typically, it could be a good amount of questions. They're typically well publicized. And this means that it might not just be an internal email, or it might not just go out to your church group or your synagogue groups um, email list. It would go out to the broad community, um, newsletters, large mailings. And it's open to people in the community that want to learn about some of the abilities or the project that you're doing, and they also want to share your opinion. So there's this give and take, right? There's an educational component that is often provided to the people in the listening session, and then there's also the learning component where the people or the organization providing this listening session, they're learning from the people. Um, the AARP recommends that a listening session um, be no larger than 25 people, right? And I found that once you really hit 20, it starts to get a bit harder. When I'm facilitating a listening session, I want to be able to look every person in the eye. I want to be able to call them by name. I want to make sure that everybody has a chance to speak. At some community meetings or gatherings, if there are a group of people, 20 people, 15 people, 30 people, oftentimes a small group of the people will be the ones that speak most of the time. So if there's a community association or a civic group and they meet regularly, there's a good chance that maybe even though there's 15 or 20 people attending, maybe just 3 or 4 people take up the majority of the time during one of their typical meetings. A listening session is a format that would limit some of the people that would typically dominate or monopolize a meeting and lift up some of the people that might not be as verbal or as talkative. And a smaller group allows you to do that more effectively. So why conduct a listening session, right? Here are a couple of vignettes that could show the efficacy of including a listening session in your toolbox of data. If you look at data and info as a plethora of tools and options, well, the listening session is part of it. So there's a hospital and it wants to hear about the safety concerns of employees when arriving or leaving the hospital for work. They mail out a survey to all employees to measure safety concerns. Here's something important to take into account. The administrative staff and some clinical employees have a docking or computer station to chart, and they can work on emails regularly. But many of the custodial, food staff, and patient transport employees have schedules that do not involve substantial amount of time at a computer or a docking station. And the survey is getting emailed out. Well, I would ask you, which employees would have access to your emailed survey? Based off of the information, could some of the employees at this hospital be undervoiced? And thirdly, if yes, why? So you can take a moment to answer. Write your answer down. So if we were to go to this hospital and look at the respondents of this survey, it would be majority the people that are administrative, the people that have access to their computers, access to emails so during the workday, so they can go ahead and knock out a 5-minute survey. And maybe the people that don't have computer time built into their schedule might not be represented as well in this survey. So by bringing in a focus group or a listening session, you're able to pull some of the underrepresented, undervoiced in the community out. So there, another vignette for you on why conduct a listening session. Well, here's an example. There are 2 neighborhoods in Southeast Baltimore. This is just a rough estimate. There is an electronic survey that went out addressing community needs. And this survey is offered online and on social media to residents who live in each neighborhood. And these are just a couple of examples. One neighborhood is in Fells Point and the other neighborhood is in Jonestown. The residents of each neighborhood, the neighborhoods are separated by less than a mile. And out of these 2 highlighted blocks, according to citydata.com, they have a similar amount of residents, right? So very close area, similar amount of residents. We're sending them the same survey, the same electronic survey. Well, one community has the fastest high-speed internet available with 100 megabytes per second. So I have here a map from bestneighborhoods.org, and it goes over some of the broadband coverage in the area. And looking at this map, um, the neighborhood in Fells Point has some of the best access to internet service, right? But then the neighborhood in Jonestown has the 1 megabyte speeds. Okay, well, you could say, all right, well, maybe like a broadband or fiber optic internet isn't available that readily in Jonestown, but that's okay because you can get an unlimited uh, data plan. You can have a high-speed data plan on your phone. You can buy an iPhone, you can buy a Galaxy, and then everybody can participate in this survey, right? Well, let's learn a little bit more about these communities. Well, in one community, the median income is $35,735 per household. That's the median household income. Um, so it might be a bit hard to buy the latest $1,000 iPhone or Galaxy or one of these super expensive phones that could provide good internet. Might be more difficult if you're making um, a lower baseline of money. Well, then, does the community in Fells Point, does this block have the same situation? Well, according to city data, it shows that the median income for this neighborhood is 131, over $131,000 per household. So maybe this block in Fells Point can afford the phone and the high-powered data plan to support that phone, and this neighborhood could also just have regular broadband service by maybe Xfinity or another provider. But where this neighborhood, it doesn't. And this example doesn't even take into account people of different ages, generations, computer literacy. So there's a chance that um, one group could be undervoiced. So a listening session targeted in the Jonestown community and some of the other communities that might not be represented on the survey, it could be a good way to supplement this survey data. I'm not suggesting replacing all surveys with data, with a listening session, but it's a good tool to add in your toolbox to be a little bit more equitable about how we get, receive, and source information. So I want to go into our first, our case study example. So much like other fields, healthcare, um, like other fields in healthcare, there's racial disparities present in hospice. There are also financial, geographic barriers that's often been cited for disparities, right? So this listening session initiative, it was to understand barriers to hospice utilization among communities of color in Howard County. Why Howard County? Well, we received funding from the Horizon Foundation. Um, the, the Hospice Palliative Care Network of Maryland received funding from the Horizon Foundation to conduct this study. But if the literature always points to this, well, the reason why there's disparities in healthcare access, the reason why there's disparities in hospice utilization among communities of color, it's because of the financial, some of the geographic barriers. Well, Howard County is one of the most highly educated municipalities in the country. It's one of the wealthiest counties in the country, yet the disparities in hospice utilization still persist, right? So what's the core? What's the root? We can't say the cliched answer of financial or educational or geographic. There's plenty of healthcare in Howard County. People are educated to a large extent, and it has one of the highest net worths. So this is just a great study to find out the hows and why of that. So this was hosted by the Hospice Palliative Care Network of Maryland. There is a Diversity, Equity, and Inclusion Council that led the work. The funding for this was provided by the Horizon Foundation. There was advisory and support and several partner organizations, such as Accessible Resources for Independence, the Chinese American Parent Association, St. John the Evangelist Roman Catholic Church, the Indian Cultural Association of Howard County, Aging Adult Services, and the Korean American Senior Association were a few of the associations reached. And we focused on five communities specifically. Um, and we used two formats. So four of the formats were virtual. There was a format targeting the Black community, the African American community. There was one focused on the Indian community, the Chinese, and one on the Hispanic. And those four were all virtual. We did one in-person listening session with the Korean community. All right. And before we got started, we had to develop the partnerships, right? So we connected with several different partner organizations that helped us get people to attend the listening sessions. You can put up a posting, you can knock on doors, but one way to get people to your listening session is by partnering with an organization that has a real advocate for the work, and partnering with someone that has the pull to get people there. When you have that combination, boom, you're going to get people for your listening session. Another way to do it is offer some kind of stipend or gift cards or some kind of incentive to get people to come. All right. Here we have Suzanne Lumpkin. She is a community member. She is a survey and research consultant. So she was able to train our entire team on listening sessions. She was able to train our facilitators, and she also trained everybody on our council that was involved in this. And we used a toolkit, community listening session toolkit by the AARP, Roadmap to Livability. It outlines and it gives instructions on what are some of the best practices to plan a listening session. It's not the only game in town, but it's one of the most thorough that I've found in my review of the literature, right? However, it is not formatted for the virtual context during COVID, the work we live in now, but we were able to tweak this and we learned a lot along the way. One of the key elements is the facilitator. They recommend getting a trusted member of the community. So this gentleman here, David, goes to a large church that many of the people in the Korean community attend. He is a very trusted member of the Korean community. He's also fluent in the Korean language, and he was the perfect person to facilitate the Korean session. Same thing with Suzanne Lumpkin. She was the vice president for a major company. She's lived in Howard County for years, and she facilitated the African American listening session. And each of these facilitators were linked to and trusted in their community. And to be a facilitator, you want to be able to be assertive, but also open. You don't want to lead people. You don't even want to be too affirming with your answers. I don't do a lot of smiling when I'm facilitating. I don't say, hey, great answer, good answer. I try to keep people to within a certain time frame. I try to help people stick to the group rules, the group agreements. And I try to elicit insight and feedback from people that aren't sharing as much. And I often will reflect back thoughts and ideas and anecdotes. This is also good for the note takers because the facilitator, it is not recommended that the facilitator take notes. Facilitator should only facilitate. And there should be at least one dedicated or two dedicated people to take notes. But when we move this process to online, we move into the tech process. You want somebody who is skilled in Zoom or Teams or the platform that you're using to be able to troubleshoot and help with tech questions and problems. And that person should not be the note taker, should not be the facilitator. You also want to have a moderator, right? A moderator online is somebody that can help take questions in the chat. They should be comfortable jumping in and say, hey, so-and-so, put this in the chat. Also, you want to have somebody skilled and versed, because if it's a platform like Zoom that offers polls, well, you can incorporate those polls ahead of time for your listening session. So you can just click it, the polls will come up, people will answer it, they'll see the percentages in real time, and then you can follow up with that qualitative question as to why. Why did they answer the way they did, right? So this is the support team we have here. This is for the Korean listening session. We have a facilitator, right? Right here, we also have a translator who was able to translate the answers into English for the note takers. Myself and Altanya, we are the co-chairs of the State Hospice Association's Diversity Council. We also have Sue Song, who served as one of the moderators for this. You don't need a tech person if you're doing this in person, but when it's online, you do want to have that tech person there. We prearrange the script. So the AARP has a template, a sample guide on how to format the script. We start off with a welcome and an overview of the day. You introduce yourself and your role as the facilitator. You could also introduce the other team members. You will go over the agenda, and then you also ask people to turn off their phones, show people where the bathrooms are, and other housekeeping information. And after that, you want to go over some of the group rules. And I like to call it a group agreement. The rules that I give or the notes that I give, I'm proposing this, right? I'm proposing this to the group, and they can choose to agree to those rules and maybe offer some other guidelines as well. But they're adults, right? Or even if they're teenagers, if they are agreed to be in this listening session, then they're functioning as adults. So we want to treat them as that and give them a chance to have ownership of the rules um, and follow those rules. So if you have a listening session with 25 people, um, the AARP and other guides would recommend that you bump up the time for that to maybe 90 minutes or to 2 hours, which could feel a bit long. But if you really want to have everybody in that meeting speak and you have 25 people or 20 people, it's going to be harder to do that when it's very short. Right now with Baltimore Southeast Safety Task Force, we're experimenting with a pop-in model. Also, Gilchrist Hospice is experimenting with a pop-in model where you can go to a community association for a meeting that's already happening, for that 1 hour, and maybe we can cut down the content and the questions of the listening session and spend 20 or 30 minutes. And we have like a ready waiting audience for that. So also when you have a champion, right? Somebody that is valuing this cause of the listening session, and they are also able to engage the community, pull the community in, that's really a golden ticket right there. I'll give an example. We all live and learn. We conducted a small listening session series in the Jonestown, Washington Hill area, and we used a popular church to meet. And the pastor, he had buy-in, and a very popular pastor, very very talented pastor, and he's beloved by the community. And the date that we picked, we were trying to get it done before New Year's. We had this fall deadline we were trying to stick to, and come to find out, the date that we picked, the pastor ended up not being available. So we weren't able to get as many people from the church community to be a part of this listening session. And in retrospect, well, no, let's build the date around the champions availability. So Sue Song, the moderator for the Korean community, was able to get plenty of people to come to the listening session and get them engaged. And that was the main reason why they were there. They were there because of her. She's somebody that had pulled in the community, and she's also somebody that was very passionate and understood the value of this tool. So if we picked a time when she wasn't available, we would not have had the same level of participation. And you want as much participation as you can get in a listening session. So what are some of the lessons that we learned? We want to give a timeline for unexpected changes, meaning if you have a listening session, you might want to plan it out 6 weeks in advance, because maybe that facilitator might not be available. Maybe you want to look at changing the dates. Maybe there could be another spike in the pandemic, right? So you want to give yourself plenty of time so you can adjust. And you also want to connect with the community partners and find the liaisons, find the champions of that organization, right? Who are the champions? And there's that formula. They have the pull of the community, but they also have the buy-in and they share the vision. If you have somebody that has the pull but doesn't have the buy-in, well, they might be able to get folks to come, but maybe they don't want to put as much energy into that because they don't really believe in it yet, or they need to know more. You might have somebody that believes in it wholeheartedly, but they don't have the pull and the connection with the community, right? So you want to find the right community partners to be the liaisons. And you also want to find the right community. So there were some communities that we partnered with, the Horizon Foundation, that were very engaged, and they really tried their all. And they got grant funding to bring people and help us facilitate. But there are some communities that just didn't have the base, didn't have the pool, didn't have the interest. So yeah, they got the grant. However, they didn't really perform. So if there's a way that you can check and look and see what partners are, what are they, is this organization meeting regularly? Do they have an active list, email list? Have you been to one of their meetings? Are there 5 people there? Are there 25 people there, right? There's different tells and ways where you can learn, like, how active are they? Like, do they have a calendar that's filled up with events, or do they have just one event a season, right? So you'll figure that out. You want to include second and third generations of the community that might be more willing to talk about death and dying. That's very specific to hospice, but I do think including multiple generations could be beneficial, right? We talk about the undervoiced. Um, we did a pop-up listening session for the Southeast Safety Task Force. There was one woman on there. She must have been maybe in her 70s or 80s. I won't say her name, but it was her first time on a Zoom call. And I thought, like, wow, that's amazing that she's here, and it's so good to meet her. But there might have been a grandchild or a child somewhere in the process to kind of prompt or help her on. Um, and you want to designate one team member to reach out and be that link with this community organization or this community liaison. Do you really want to have 2 or 3 people in your organization reaching out to the liaison for another partner organization? That can leave room for things to get confused or mixed up or muddled. Um, and if English is not the first language of the participants, well, then we need to find somebody that can facilitate it in their native tongue. And I'm not suggesting, okay, we'll get a translator so the facilitator can have what they said translated into their language. No, 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 no. You want to have a facilitator who natively speaks the language and have the session conducted in the language of the audience. And we can get a translator that can translate it back into English for people that aren't speaking that language. You want people to feel as comfortable as they can in the listening session. So a tale of 2 listening sessions, right? So there is one community, St. John the Evangelist Catholic Church in Colombia, and they have a very large Hispanic population, right? And the people that were the liaisons for the Hispanic population at the church, which is huge. I'm talking several hundred people, maybe closer to 1,000 members of the Spanish-speaking population, right? But the 2 women that were our liaisons for for the listening sessions and for the Hispanic community, they were both European. They're both white Americans, right? And neither one of them speak Spanish, and neither one of them are part of the Spanish-speaking or Latino community at the church, and their hearts were all in it. I think they're on the church's diversity and equity committee. So they had buy-in, but they didn't have the pull with the Hispanic community, right? And we didn't have that same level of trust, so we didn't have the same numbers, and some of the people that came on didn't turn their cameras on, so they didn't have much buy-in. And our facilitator really had to work hard and push to get people to even to answer questions. And then you compare that with the Korean community, right? Dr. Sue Song, she was president of the Korean American Senior Association. She was also a high-ranking officer for the Howard County, I think the Department of Health, the Department on Aging. So she had a lot of respect within the community. And she was able to, at her beck and call, invite members of the Korean community to come together and be a part of this listening session. So we got a lot of great qualitative data um, and insight for the Korean listening session. The only drawback is that, like I said, we tap out at 25, but the room was almost standing room, and we had over 30 people there. So that was a bit harder, but better to have a little bit more than not enough. That's my one philosophy. So I want to go over some of the findings with you. So right off the bat, we found that synonymous among all the communities, there was a high level of unawareness about what hospice care and palliative care was. So there was an extremely high level of unawareness of hospice care, palliative care with the Korean populations, but with the Chinese, Korean populations, about 50%, over 50% did not know what hospice care was, and the African American community, 20% didn't know what hospice care was. Latino, nearly 40%. So we have that unawareness right off the bat. And then here is where we're really hit by unawareness, right? Where can you go to find out where hospice care is, right? And 94% of the Korean population, over 75%, 78% of the Latino population didn't know where to go. The African American population, half didn't know where to go. So largely unaware. And then you look at, well, who's unaware of that palliative care and hospice care was covered by insurance, right? 94% of the Korean population, 75% of Latino, Indian, Chinese populations, African American population was another, over 40%. And then you have, what's your experience with this service, this hospice service? Well, you have a lot of people did have some experience with maybe a loved one or a community member in this program that we call hospice, right? Um, and then, well, what was there favorability? Was there a higher favorability among people in some communities? Um, as we said with the African American, there were about 30% that didn't know what hospice care was. So 64% had a loved one or a friend. The Latino community, 44%. The Indian community, over 50%, knew somebody. The Chinese community, only 17% knew somebody on hospice or had a loved one or community member. Only 6% in the Korean community. So there is a wide variation of experiences. And then when we look at utilization in Maryland, well, Black people, African American people account for 30% of the population in Maryland, but we only make up, according to the Maryland State Health Commission, we only made up just over 20% of the utilization of hospice. White people in Maryland make up half of the state, 50%, but they're overrepresented at over 70% in hospice and palliative care in Maryland. And these trends, these disparities exist in the other communities. So even in Howard County. So it's important, right, to know why. Why do people not know about this, right? Or why aren't people using it? Well, they're not aware. And there was a paper, I believe out of the University of Florida by a scholar named Armstrong, that said that, well, people are just not as aware. Well, African Americans have a lower level of trust, right, of hospice. There was, and healthcare in general, because of some of the racial and economic disparities that have happened in healthcare over the years. And then there's other literature that showed that among all 5 of the groups, right, there's a high level of unawareness about what hospice and palliative care is. How do you pay for it? Is it covered by and insurance. So what we were finding in our surveys linked heavily to the reasons that were in the contemporary literature. Some of the reasons cited among some of the groups, cultural reasons. There are some cultures where you take care of your parents, you take care of them in the home. Um, and then that ties into lack of information. Many people don't know that hospice is available in home, that most of the people that are receiving hospice service, they don't receive it at a physical place. Hospice isn't a place. Most people receive it in their own home, or if they're in an assisted living, that is their home, well, they will receive hospice there. So this lack of information was very prevalent. Also, language barriers for out of all the groups except for the African American group cited language as a barrier. Um, so that was highly prevalent. Um, Many in the African American community would like to hear about hospice from a trusted community member, maybe like a local leader or even a clergy person. So if information came out of a church or a faith community, maybe they might take that a little bit better, or be a little bit more trusting of this information and resource if it just came from a medical establishment as opposed to it coming from a medical establishment. And then in the Korean community specifically, they prefer information to come directly from their primary care, right? Or their, their specialists. Among all the groups, and this was a bit of a surprise. I did not find this in our in my review of the literature, but libraries were one of the most common places where people wanted to find information about hospice, right? So if you look at the best ways to connect, preferred outreach, many of the people um, shared that, well, a faith-based organization, yes. Um, Two communities, the Korean and African American community wanted their senior housing center or assisted living to share it. The Korean and Latino wanted their physicians to share it. The Korean language newspapers, right? That was brought up. But libraries, right? Who knew that libraries would be the most common preferred place to get information among many of these various groups? So that could be new data. So we did ask about the experience um, of what hospice was, of how, the people that did have some family experience with it, they had a lot of praise and supportive things to say for the caregivers. A lot of information was given and shared during this process of a listening session. There's give and take. So after learning about hospice and palliative care from today's session, how likely are you to share this information with your friends or family? And given that most of the people were not even aware of what hospice was, right? By the end of the session, by having this back and forth, it was able to build trust up, right? Um, and we had 19% of respondents. We used the combined means formula among the various groups, but 19% said they would likely share this information with not only their friends, but their family. But then 68% shared that they would share it with their friends and family. So we're pushing like around 90%. And that's coming from a point where most of the people in the listening sessions didn't even know really what hospice or palliative care was. So there's the tenet of community-based participatory research, and it talks about this collaborative research, this journey. It helps build trust between the organization providing the research, as well as the as well as the community participating in the research. There's a scholar, Karina Hughes, out of Florida State University. So she has an article that came out on community-based participatory research. But the idea is that you're partnering with the organization, you're building that relationship before the research even takes place. So there's this strong link of partnership. The research that's given is not just owned by the researcher or the organization, it's shared knowledge. Everybody, every community in this group knew that they would get data from us about our findings, right? That's great. And they also knew that the information that they give, the findings that we get, will be addressed and shared in the community. The research would be applied in the community. These are all tenets of community-based participatory research. So this paper out of Florida says that when organizations use this method, it helps build trust. And especially when communities that are undervoiced or there might be a lower level of trust towards healthcare, it could be a way to build trust by modeling that. And then, so what are some of the lessons that we learned? Well, we know we want to approach and give information about hospice at libraries and faith-based organizations. Now, if you put a listening session together, it might be different, right? You might need to get provide information in different areas, right? A listening session could be used for a neighborhood. It could be used for a demographic group. It could be used for people at a specific job or center, right? There's just a wide range. We worked with people that were from a multitude of racial communities of color, and they were mostly seniors, right? And the feedback that we got is that these multiracial people of color want to get their information from the library and from faith-based organizations, right? And or from clergy. So that means that for them that works, but it could be different for other communities. So we wanted to continue more research, and then we wanted to provide we wanted to provide information about our findings to the community, and we wanted to better normalize hospice and palliative care, right? That needs to be normalized. Physicians need to hear about it more. People weren't hearing about hospice from their primary care doctors, so that could mean that we could have some more time with the primary care doctors in Howard County. And then we also want to, hospice organizations should also hire staff that represent the community. So if you have a large Spanish speaking population, you're going to want to get some Spanish speaking people on your staff. You know, if your population has a good amount of African American patients, you're going to want to have some African American people on your staff and at different levels of leadership within the organization, right? Because that's what we heard in our data, right? And that's also consistent with the contemporary literature in the field. We also want to follow through. So what commitments were made for this listening session throughout the process? Well, we committed to follow up with learnings, right? So we made sure that we did a learning for each of the communities that participated in the listening session. And we also want to provide outreach to some of the primary care providers in Howard County so that they can be a little more able to provide knowledgeable information about hospice, so it could be more of a support to the community. And our next steps were a listening session series in Jonestown. We completed 2 of them already. The next one that we do would most likely be at Helping Gut Mission, and we're waiting for Omicron numbers to go down. So I think that's going to happen pretty soon. So if you have any questions, please feel free to ask those questions now. I will stop sharing. All right. Well, thank you so much for your time.
This meeting is being recorded.